I would just like to welcome everyone to our panel on Ontario health teams. We're really fortunate to have with us a fantastic panel of people to discuss Ontario health teams with us from a number of different perspectives. So I'm just going to introduce our panel members first, and then we will move into starting. The format is going to be each panelist, and there's one presentation that's shared. We'll have about 10 minutes, and then after that we'll have a question and answer period. And I already have one question in advance, so don't wait till the end to pop your questions into the Q&A. And also don't forget to vote for your favorite questions as we are getting going. So first I'd like to introduce the panel. We have John Fleming. So John is a patient advisor at Hamilton Health Sciences and co-chair with the Hamilton Ontario Health Team. He's extensive board governance experience and is a retired Ontario Deputy Minister and City Manager. Following John, we're going to have Dr. David Price. David is Professor and Chair of the Department of Family Medicine at McMaster University since 2006. He was instrumental in producing the Patient Care Groups, a new model of population-based primary healthcare for Ontario report, commonly referred to as the Price Report, and currently chairs the Primary Care Advisory Table on behalf of Ontario's Ministry of Health. He'll be followed by Dr. John Lavis. John is a family physician who serves as director of the World Health Organization's Collaborating Center for Evidence-Informed Policy and as the director of McMaster University's Health Forum, where he's also a professor in Department of Health Evidence and Impact. From an Ontario Health Team perspective, you'll also know him as co-lead of the RISE platform and a key advisor to the Ministry on Ontario Health Teams. And finally, we'll have a joint presentation by Nadia Serrani and Alison Costello. Nadia Serrani is the director of the Primary Healthcare Branch at the Ontario Ministry of Health, and her role includes policy, funding, and accountability for key elements of Ontario's primary care sector, and lots of portfolios. Family health teams, nurse practitioner-led clinics, Aboriginal health access centers, community health centers. In addition, she's also responsible for the midwifery portfolio and northern stuff and like everything. And Alison is the director of the Ontario Health Team Implementation and Supports Branch. So I'm sure you all want to hear more from them than you want to hear from me. So we'll move into our first panelist, John Fleming, and he's going to talk about the genesis of the Ontario Health Team in Hamilton.
Thank you very much, Mike. I appreciate the opportunity to do this, and I was thinking about this earlier and wondering how, particularly with David and I both as a part of this panel, how Hamilton was chosen to talk about Ontario health teams. But I want to say proudly and objectively, whoever made that choice made a really good one, because I think this is a really unique structure and piece of process that has been put together in Hamilton. I wanted to bring in a bit of an introduction, as you mentioned, Dr. Green, to what's been done in Hamilton, frankly, long before the advent of Ontario health teams, because it's important to where we are now and how we've built the success that we've built so far. Way back in 2013, there was an organization created called the Hamilton Anchor Institution Leadership Table, better known as HALE. And it was a network of CEOs of Hamilton's largest public sector organizations, school boards, McMaster University, Mohawk College, both the large hospital systems, the City of Hamilton, the LHIN, the police, the Hamilton Community Foundation, the Chamber of Commerce, and even a roundtable for poverty reduction. They began meeting in 2013, 2014 in an effort to address some of Hamilton's really most complex challenges around high poverty neighborhoods, poor health outcomes for some groups and neighborhoods, lack of educational attainment, problems with job creation, And I want to say part of the genesis of this was based on the findings of a series called Code Red, done by the Hamilton Spectator, which really demonstrated a difference of 21 years in life expectancy between Hamilton's richest and poorest neighborhoods. Fast forward to 2017, several members of that HALE group convened another organization called the Hamilton Community Health Working Group that was co-chaired by our own David Price, who you're going to hear from shortly, and Terry Cook, who is the Chief Executive Officer of the Hamilton Community Foundation. That HCHWG worked for 2 years to develop collaborative and innovative approaches to better address the health needs of some of Hamilton's most vulnerable citizens. This is 2017 we're talking about. That work culminated in a report called A Healthy Hamilton, which was released in 2019. The approaches recommended in that report included piloting more integrated care between acute care, primary care, home care, and community care in several areas of Hamilton. Beginning to sound a little familiar, folks? And then lo and behold, in 2019, along comes something new from the Ministry of Health called Ontario Health Teams. So all of that early work really enabled a fast start for Hamilton into OHT thinking. Using the foundation that had been built over those several years, we've really continued that collaborative and cooperative effort from the beginning of our earliest meetings of what eventually became the Hamilton Health Team. And I might just say that at my ripe old age, I have nearly 50 years of experience in the broader public sector, working around a combination of health and human service organizations. And whenever I talk about the Hamilton Health Team, I usually make the comment, I have never in that 50 years seen the kind of cooperation and collaboration that I've seen around our Hamilton Health table. And frankly, I'm very appreciative of the stance taken by the CEOs of the two very large hospital systems in Hamilton to not make this be, or even be seen to be, a hospital-driven venture, but rather a patient-led venture. I'm a survivor of a life-threatening cancer, as is my wife. I bring a frequent flyer patient perspective to the work that we've done. And we have embedded a deeply held principle that patient-centered care should be a central organizing value in all the work that we do. So the recommendation to the founding group of those two hospital CEOs was that the best way to demonstrate that would be to appoint two experienced patient advisors as co-chairs of the quite large working group. That was myself and Bernice King, who is a patient advisor in the St. Joe system in Hamilton. So let me explain a little bit about that co-chairing approach that we took. It evolved into an arrangement where one of the two, that was me, took on a role of chairing the meetings of our various governing structures, with my colleague Bernice becoming what I call the relentless conscience of embedding patient and family advisors in every part of the team and at every step of the way. It's been absolutely core to what we've done. One final comment about the HHT body has gone on to work through two evolving approaches to governance in our organization. But it's important to know that at the very beginning, we all agreed to and signed off on a charter which defined then and still does our values and our principles. I just want to read you the lead of that charter because to me it's instructive. We, the undersigned, and there was indeed signatures on this document from many people, we, the undersigned leaders of a strongly determined team of healthcare delivery organizations, community service providers, clinicians, and patients, undertake to work cooperatively and collaboratively, thoughtfully and diligently to create a dramatically new and highly patient-centered health system for Hamilton, a model that builds on the earlier successes of our partners. Lots of work has been done on the critical importance of the engagement of the primary care community. We believe, been one of the leaders in this respect. And I'd like to turn now to my colleague, David Price, to describe how effectively that's been embedded in our work, how central it's been to Hamilton's strategies and tactics, not only in terms of the Hamilton Health Team, but in managing COVID-19 in Hamilton. David, over to you.
Thanks, John. And I'm not actually sure I should say anything. I probably, I would vote for you if you were running for political office. That sounded fabulous. And gee, folks, can I just turn it over to John Lavis, because that was great. You don't need to hear anything more from me. So primary care, as everybody on this call knows, or this group knows, is not a coordinated, organized group of individuals. And I think we're all very conscious or cognizant as family physicians that if we speak for on behalf of family physicians, we're really just speaking on behalf of ourselves or maybe our local colleagues. And I think the operative word that John used was engagement. We didn't presume to know what the structure would look like, how to bring our colleagues on board, and in fact, whether they were interested in coming on board. And so we had a number of engagement sessions with family physicians and had an open invitation, and we did it in multiple different ways and different avenues. And I just want to pay tribute to my colleague Kathy Risden and Tammy Packer, who were a large part of leading that process. And really, it was about having early morning opportunities. It was about having late evening opportunities. It was about having opportunities that were both virtual and in person. And as a result of those conversations, I think we've been able to bring a fairly cohesive, coherent organization to the Hamilton Health Team. Which doesn't mean to say that we're all rowing in the same direction. It doesn't mean to say that we are completely aligned with all of the goals, and COVID, as of course, has thrown this completely upside down. But I will say that having had the conversations as a group of family physicians, having had those conversations in partnership with our public health colleagues, having those conversations with our specialists and hospital colleagues has actually made a huge difference to the pandemic response. And I think that was really illustrative, that we were able to coordinate and organize care in our community pretty efficiently, and certainly with a great degree of coordination and organization. We were able to share out PPE in the early days. We were able to start the IPAC conversation early and to coordinate it. So it really has made a large difference. The other thing that I think has been unique about our organization in Hamilton is that we identified patient populations. We identified essentially the frail elderly, those that were either adult or adolescent and pediatric suffering from mental health issues. And we also just started to focus on some of our most vulnerable homeless type populations. And that really, I think, has been illustrative in how we've been able to coordinate and organize ourselves. And I think John left you with a really positive message. I also, with my work across the province, know that we are not unique, that this kind of coordination and organization has happened in many communities across the province, to a greater and lesser degree. There have been some real successes and there have been some real challenging areas. But I think if I had to say what has been the secret ingredient in our group and in elsewhere, it is the fact that we've engaged primary care. We've listened to their voices of a disparate number of people. I've been super, super impressed with the willingness of family physicians and other primary healthcare providers, nurse practitioners, social workers, dietitians, physio, rehab, like the works. And you know, forgive me for not including everybody, but they have all been at our coordination meetings, and they've really demonstrated a willingness to engage in this conversation. And I think what fundamentally this illustrates is that primary care system recognizes we're not coordinated, we're not organized. We have a lot of work to do to become an organized, highly efficient healthcare system. And I'm hopeful that the Hamilton Health team will help us start to achieve that goal. In any of those sort of type of organizations, you need to have the evidence, you need to have the coordination, you need to have be able to draw on resources that are bigger than yourselves. And I think that's where John Lavis comes in. And so, John, I'll turn it to you to really start to highlight some of the work that you've done helping coordinate our efforts as well as across the province.
Great, thanks very much, David. I'll just pull up my slides. Mike Green or David, can you just reassure me in a second that you can see my slides?
All good, John.
All good,
Right.
great. So I'm just going to talk a little bit about Ontario Health Team's primary care and available supports. So when I look at the cast of characters involved in this, it seems most of you are probably very up to speed, but OHTs are a new way of organizing and delivering care, and primary care is right at the center of this, moving to achieve the quadruple aim. The long-term plan is clinical and fiscal accountability, but that's a few years off. I've spent a few decades, I think I'm now getting up to my third decade of studying healthcare in Ontario, being an active participant in it. This strikes me as landmark development in the system as when we introduced universal coverage for hospital-based and physician-provided care. And I would really love to see the end of pilots in this province, and that we think of OHTs with every step as a step towards full-scale transformation of the system. So RISE, that I co-lead with Rob Reed and Jeremy Grimshaw, is one player in the ministry's OHT central program of supports. We shamelessly pilfered ideas from the technical assistance supports that were available to support the introduction of accountable care organizations in the US. All the resources that we and others produce to support OHTs are available through the RISE website. We finally have a web page up specifically focused on the primary care sector. We'll be adding to that over time in partnership with a number of the key players in the sector. We'll soon also be adding a web page that helps you better navigate the central program of support. So if you need help with X, I should turn to this group. If I need help with Y, I turn to someone else. And we've just launched a set of online communities of practice. And specifically, I'm going to talk about year one priority population shortly. With them, we're calling them learning and improvement collaboratives. And for those of you who've been involved in QI work before, you'll recognize Quorum from the old Health Quality Ontario. And we're using that site to support these communities. So I mentioned year one priority populations. That's one of the two big important things to be paying attention to with OHTs. OHTs are going to be expected to move the needle on quadruple aim metrics for year one priority populations. We found most of the OHTs in cohort 1. Cohort 2 is going to be announced very shortly, focused on older adults and or people with chronic conditions, people with mental health and addiction issues, and people who could benefit from a palliative approach to care. But of course, COVID-19 has consumed many people for the last 7-8 months, and that's also critical going forward. But OHTs, in addition to working with these populations as a step to becoming accountable for their entire attributed population, also need to put in place the 8 OHT building blocks. When I was thinking about which of them are most important from a primary care perspective, recognizing all of them at the end of the day are, 3 really struck me as being front and center for primary care. One is population health management, where some of the supports that are particularly prominently involved are RISE, the Center for Effective Practice, and the Health System Performance Network. Then within digital health, there are 2 pieces: digital tools, where some of the key players are Ontario MD, the eHealth Centre of Excellence, and the ministry's digital health branch. And then on the data analytics side, integrated decision support, Mike Green and his colleagues with Inspire PHC, Rick Glazier and his colleagues with OCHPP, and then ICS. And then on the primary care leadership and engagement And absolutely critical roles being played by AFTO, the Alliance for Healthier Communities, OCFP, the OMA with its recent physician engagement webinar and new white paper. So many of these groups operate across the building blocks, but they're playing particularly critical roles for these 3 building blocks. And then when I was thinking a bit more about where primary care is well positioned to lead, in the US, the experience was primary care has been essential when accountable care organizations were successful. And in the US, they often talk about 3 curves. Curve 1 is more the acute episodic care. Curve 3 is more the public and population health, where you're tackling the determinants of health. But 2 is sometimes called clinical population health management. And for primary care teams that are working with rostered populations, this has probably become second nature for you, but you're unique in the system, and hospitals and others need your leadership to help with this move to more proactive management of chronic conditions, thinking about populations segmented according to those with shared needs, putting equity at the center and making sure that all groups are able to benefit. Thinking about interventions in ways that are individually focused but proactively applied, and applying good clinical care consistently across entire population segments, not just the people who walk through the door. So a lot of this is second nature to primary care, but this is the type of model we need operating across the full continuum of care, and primary care is so well positioned to be leading this push. I have a couple of slides that I've stolen from my co-lead, Rob Reed, and I would just refer you to the RISE website to hear more about these, but some of you will recognize the Kaiser pyramid, and primary care, of course, is cutting across all of these levels of the pyramid, very involved in care management, coordination, and so on. And you'll see in the first of the 3 kind of vertical segments, team-based primary care, again, cutting across all parts of the segments of the population pyramid. And many of the health programs and interventions, again, are going to be very familiar to those of you who've been at the vanguard of proactive primary care for a long time in this province. But this is the type of thing we now need to be rolling out across all parts of the system, with primary care at the center. And then if I just back to data sources, your electronic medical records in primary care are going to be an absolutely essential input to understanding the attributed populations being cared for by OHTs, but they'll also need to be complemented by many other sources of data. And then your EMRs ideally will help you document, track, and have prompts to be proactively and in a much more coordinated way providing supports to patients, families, and caregivers. And again, it's second nature to most of you in primary care, the chronic care model with down at the bottom, the patient and the proactive care team. But primary care needs all of these other pieces of the system working well around it in order to deliver on its promise. And that's partly what OHTs are meant to accommodate. And so when we talk about the chronic care model, again, a lot of this will be second nature to all of you, but it's the type of things that if primary care were even better supported by the broader system with connections to home and community care, the hospital sector, and so on, you could better deliver on the promise of primary care. So just to wrap up, my sense is primary care is well positioned to lead the push for shifting that second curve. And I think a lot of this is second nature to many of you. And now this is your opportunity to roll out this thinking across all sectors, not just primary care. I think OHTs provide a mechanism to better align all of the other resources in the health system to help achieve this shift. So you've been there in many cases for a while, but now we need your thinking to be bringing in home and community care, shifting the orientation in hospital care. RISE and other partners in the OHT Central Program of Supports will increasingly be supporting this shift and these alignments, and we'll soon have a new RISE Center for Effective Practice brief about this. We'll soon be launching a coaching program, but there are a number of other partners, as I alluded to before, that are absolutely essential to this. I've aligned them with particular building blocks, but many of them are working across all of them. So that's a quick wrap up. If you want more information about RISE, you can go to our website, and we'd encourage you to think about joining RISE's quorum space to participate in the communities of practice or the year one priority population working groups. So that's it for me. Thanks, Mike. Over to Alison, I think. Alison and Nadia.
I think
Yeah,
so.
so Sherry, I think Alison and Nadia, you have some slides?
We do, and I've asked Elliot if he's able to share them, as I do not trust myself to try to do that on my computer. And,
we have that.
Sorry, Elliot?
Yeah.
Thank you. And Nadia's computer has crashed while we've been here, so she's trying to get dialed back in. So you'll have me for a bit, and we've well practiced our lines, so I'll do a good fake Nadia for you. So we wanted to give a bit of an update. If you can take me to the second slide, thank you, Sherry. John spoke a little bit about this, of course, and we've been speaking about it since the meeting started, that Ontario Health teams have been introduced more recently as a new way to integrate care locally for the provision of all the services that a patient might need to experience, to have a group of providers working as one team across the full and coordinated continuum of care. And this is a little bit of our timeline for how we've supported that introduction. So the concept of the model was introduced in the People's Healthcare Act 2 years ago almost. We released a call for self-assessments in the spring of 2019. And following that, we supported a lot of teams through a multi-staged application process and have supported 24 teams in an initial batch to be approved last fall, and a further 5 more recently. And as John mentioned, we invited 17 teams in the summer to complete a full application that we received, and we are hopefully very close to being able to announce new teams coming forward. We've noted on this slide as well that in partnership with all the program partners that John just mentioned, we have and we will continue to kind of support where it's appropriate for the ministry to take on that role, support guidance to the field where we feel like it's most needed. So we're noting there that picture that you see is a collaborative decision-making arrangements guidance document that was released in July and spoken to in a little bit more detail at a webinar that we had in August, where the minister, deputy, and a lot of our support partners, including Rob Reed and Ross Baker, were able to speak to some of the experiences that they've had in supporting integrated care and how they are part of our broader network of supports for teams that are implementing the model. So on the next slide, we have really reflected through this process, and I think if you had been paying attention to the way that we have been communicating our OHT work more recently in announcements that were made over the summer, that we have heard from a lot of OHTs, and we had outreach to all the teams in June and July of this past summer to talk to everybody about what their implementation has been looking like through COVID. And we have heard from a lot of teams that COVID did provide a little bit of a proof in the pudding to their integration and their ability to work together as partners across the sector. And I think especially in a time of crisis, how they could use the work that they had been working on over the past years, and maybe 10 or more plus years, John, as John Fleming, as you've mentioned, to really have the tables, have the trusting relationships to be able to work together to nimbly support a response locally to COVID. So we've noted some of those successes on this page that we had heard from teams, and I will be honest to say that some of them are successes, but some of them certainly point to where there are continuing challenges and where the ministry and other partners might need to be able to deploy supports to help along the way. These we've pulled that are specific to primary care as well, where we know that there had been a lot of deployment of partnerships across teams to support testing, assessment centers, really having that partnership in place to go where the need what most was. And we have some examples noted there on the very bottom based on team specific examples. So we actually have been kind of gathering a lot of that information and hearing from teams that there is a pretty strong reflection where they've been able to capitalize on it. And I think some teams might still be struggling with the ability to do it, but there's a very strong reflection that there is a need to make sure that we continue some aspect of OHT work, no matter what, through a pandemic, as it is providing the platform for these teams to work together across sectors to support a broader population. And we really want to make sure that we can capitalize on that success. And as you've sort of seen through John Lavis's slides that he presented, that the areas that teams are focusing on for their year one populations have not changed too much over the year and a half of implementation so far. But I think a lot of teams have noted that where they had wanted to put their initial focus was really confirmed through COVID, that those were the most vulnerable. They were the ones that needed the most support, and maybe the way that they supported them might have changed, and the ways that we can sort of hear more about that and support that best practice sharing is what we'll be most interested in. So on the next slide. So what we wanted to highlight on this slide is that the timeline that we showed earlier noted that we had a open call for self-assessments that we had indicated would be repeated until we had provincial coverage of OHTs across the province. And while we are repeating the process to support OHTs through a full application that will be approved by the minister to begin implementation, we are being a bit more targeted in how we're taking that approach, as through receiving over 150 self-assessments in the first round, we kind of know where most of the activity is across very many regions, and we want to be a bit more targeted to reach out to the teams to understand how to bring them together, understand what supports they might need to advance. And we've changed our approach a little bit to reflect that. So we've noted that on the slide, the first wave of OHTs and implementation have helped set the course for our implementation moving forward. And some elements of the model and the processes that we've confirmed as a result are, while in the early days we had suggested that primary care, home care, and hospital care were preferred partnerships that should be in place across OHT, the full application now reflects that those are required partnerships and services that should be in place for an OHT to be approved. And a lot of the work that we're doing right now is to focus on making sure that our OHT areas of the province that are not yet supported by an OHT or one in development, that we're really making sure that we're aligning that work and the formation of OHTs based on how patients have historically accessed care, and using the attributed populations that those reflect to help guide us in helping teams come together. So that we've reflected in a new full application process that we released in the summer, and really want to encourage the teams to really pursue broad partnerships that will ensure that as most services as a patient may access are part of what that team is working on. And I think, especially through COVID, where that has proven to include partners that care for those in congregate settings, those that are more vulnerable, where public health had not been at the table, how they could work to integrate them, where long-term care had not been at the table, how that can be worked to integrate it as well. So finding out a little bit more about what that will take to be able to advance. So I'll just go to the next slide, and I'm not sure if Nadia is on the line. Oh, she's back. And I don't know if she wants to speak to this slide, if she's functioning.
I'm functioning, but you're doing a great job, but I can jump in if you'd like me to. It's your call.
Please.
And I think this slide, it's neat to end with this slide. I get to go last, and I get to reiterate, I guess, a lot of the things that we heard from the rest of the panel members about primary care leadership, primary care engagement, and, you know, the breadth and plurality of primary care, and making it, I think, challenging, I would say, to be true to those concepts. And I think one of the key lessons learned, and not only in Ontario, but in other jurisdictions, is that strong leadership and engagement by all primary care providers is really key to the successful implementation of OHTs, given primary care's foundational role in the healthcare system. And so I think, you know, historically, Ontario has been a place of innovation, redesign of healthcare delivery models, especially in primary care. But I think what we've heard from others on the panel and a lot is we do tend to struggle with spread and scale up of innovation across the province. So I think, you know, having other supports in place and community of practice, with John mentioned and others, is really important. And we have an opportunity to overcome the challenge of innovative scale and spread I think in a more formalized way, for sure. What we're also seeing, and I have to say, you know, I'd be remiss if I didn't say what we have been observing through COVID and even prior to COVID, is the primary care sector really making concerted efforts to organize locally and in different ways, whether it's primary care networks or other organized structures, not only to improve the care for patients, but also assist and help each other on with health and other social service organizations. So I think somebody else on the panel mentioned, I think it was David, on the regional distribution of PPE or assisting with COVID assessment centers, right? And I think those are excellent examples of how primary care was really along a great track of organizing locally. And I think John mentioned this at the beginning, is in some places of the province, this was done well before OHTs and well before COVID. And how do we take those lessons learned and make sure that we're sharing best practices and resources and understanding, you know, what are the supports that are required to make sure that the critical success factor that we always talk about and that we always say, and it's not people on this panel, or it's the evidence and the research is saying for an integrated system, you need to have primary care at the foundation, and you need to make sure that primary care is engaged and providing that sort of clinical leadership that I think you see on this slide. And I think as part of the evaluation of the full applications, the teams were assessed in terms of their degree of primary care leadership. Hard to do that, but tried to get at it at a granular level. What was the composition of primary care organizations? So I think on the last slide, Alison talked about it being a requirement, but I think digging deeper into that requirement and understanding the breadth and plurality of primary care, whether it's you know, different capitated models and affiliated with an interprofessional team and all of the team members within a primary care team, and making sure that that breadth and plurality is well understood as meeting the requirement, I would say, of an Ontario Health team, which is a critical challenge. Huge thanks to sector partners, the OMA, AFTA, OCFP, the Alliance, academia, and others, to figure out how we best support teams. And I think John talked a lot, you know, about how can we best support for clinical and physician engagement. And I think we have a lot to learn. And I think you know, primary care leadership is a crucial element. And so really looking forward to the discussion today, listening, maybe not having all of the answers, but really listening to figure out, you know, our way forward to ensure the successful implementation of OHTs with primary care as the foundation.
Great, thanks, Nadia. Is that the end of the slide deck?
That is, yes.
If it is, then I'll have Sherry, if you can stop sharing so that we can just see the speakers again. And I think David Price might have one more comment just before we go to the questions. So I can get people to look at the questions in the chat. So the session Q&A, take a look. Don't forget to vote for your favorite questions. And then I'm going to scroll through the questions and ask them to the panelists. So while David makes his last couple of comments, if people could take a look at those questions and vote your favorites up, that'd be great.
Thanks, Mike. And my points are very brief. The first is, I think the government ministry, sort of Alison, Nadia, they deserve a huge amount of credit for requiring the OHTs to have meaningful engagement of primary care. And that was actually driven by government, because I think many of the applications would have been very different. And that is a real kudos to them. So there's the kudos. The flip side to that is primary care hasn't had a history of being well organized. The only groups that we have are the family health teams and the Association of sort of our AHACs, some of the Indigenous-led, nurse practitioner-led clinics, et cetera. But it's a loose affiliation, and we have not had a formal organized structure for primary care in this province, much like the hospitals have and so on. And that's notwithstanding the work that the Ontario College of Family Physicians does, the SGFP, et cetera. The challenge, I think, is that we don't have a formalized, organized coordination of primary care at the community level, layering up to the provincial level. And I think John Lavis talked about the huge potential that we all have if we can coordinate and organize primary care. There is still work to be done. So I don't want it to be left with a Pollyannish kind of idea that we're there, because we are far from there, and we're hearing that across the province. And our challenge is going to be how to get from where we are now into an integrated, organized, coordinated form of primary care. Thanks, Mike.
Okay, great. Thanks, David. So this is great. I see lots of activity on the side with questions and people voting. There have been two questions that have been going back and forth between top ranked. I'm going to start with the first one, which is how does Hamilton deal with the issue of compensation for family doctors' time who are involved in non-clinical activities in building the OHTs? This is a support for physician engagement and leadership, particularly thinking about solo or small practice family doctors who still have lots of patient care to do.
Yeah, it's a critical challenge. I'll jump in there because this is a big issue. There is very little. We've managed to carve out a little bit here and there, but when I mentioned that we had huge numbers, like over almost half the family physicians in Hamilton attended and more than one of our sessions that was 3 hours long or 2.5 hours long, we fed them, and that was really about it. And I think we can go so far on voluntary contributions, but we need to figure this out. Those of us, for example, myself, who are in an academic role, we are on salary. We're paid to do this kind of work. But our fee-for-service and our capitated physicians aren't. And they still go home to their patient load and their inbox at the end of the day. And this really is an ongoing challenge for the system at this point.
All right, the next one I'm going to take. Oh, Nadia.
Yeah, I can comment if you want. And I do think this is a challenge. I think, the voluntary nature of, that primary care has stepped up to the plate to do is a real challenge. And, I won't say that that's not a challenge because I think that's something that we need to address if the ministry is going to say clinical leadership and engagement is critical to the success of OHTs. And we're hearing the challenge being a lot of voluntary time that's left to chance. And so how are you going to get clinical leadership and engagement if you're not thinking about, investments? But I think Alison might have an addition to the answer, add to my answer to this question, because I think we've made some traction on it, but I do think we have a little bit more to do. So I'll give it to Alison to tell you a little bit that we've tried to do.
Thanks, Nadia, and I don't want to bud John, who has his hand up, but it does follow so closely to what Nadia was saying, so I will. Which is that in the summer, and I'm sorry that I didn't mention it earlier, in the summer when we had announced the approval of new teams and the invitation for more teams to become part of the process, we also announced the availability of implementation funding for approved Ontario Health teams that includes a category of expenses for physician and clinical leadership, sort of said, which is the time that people have been putting into this so far has been goodwill, off the sides of desk, totally exhausting. We've heard that. We heard that a lot through the calls that we had in the summer, but very, very many times before that as well, from sector partners, from everyone we speak to. We very much understand that that is part of what is needed to keep the engine going. But I would also say, reflecting on what Nadia shared on the slides is acknowledging how important it is to make sure that we create the space for these to be supported and led through primary care, through that physician and clinical leadership, that we, put our money where our mouth is and really make that part of the model going forward. So that's been announced, and the teams that are eligible for that funding are undertaking the work to be eligible to receive it very shortly.
And I see John has his hand up. John, do you have a comment on this question?
Yes, I do. The last two speakers, really. First, I wanted to say that the challenges that were raised about primary care physicians and the impact, frankly, on their livelihood is very real, and I respect that. But it's not limited to that sector of people who are participating in this effort. In our own Hamilton Health Team work, we've seen a lot of time given by organizations who have seconded folks and all the rest. And Alison, yes, are very cognizant of the fact that finally the ministry stepped up and made some funding available. Excuse the pejorative word, finally. Believe me, I've been in Queen's Park. I fully understand the fiscal pressures, but this is a complex piece of change that we're trying to engineer here. And just the simple leadership and management of that kind of change process carries lots of costs with it. And it's something that we need to continue to focus on. Just yesterday, Alison, we received something that starts to sketch out a little bit more about how that funding might be allocated. It felt to me on a first read that it had a very strong COVID-19 focus to it. Nothing wrong with that, but there is more to the development of the whole Ontario Health Team process than, frankly, managing the pandemic challenge. So those are the comments I wanted to make. Thank you.
Okay, great. Thanks, John. Next question I'm going to pull up, and I see there's a comment on this question from Camilla, and that's an important reflection as well. There's a question from Karen Hill about the development and implementation of OHTs and how First Nations communities have been included. Is there someone on the panel who would like to take that one?
I'm happy to start to speak to, and I'm sorry, Mike, I'm only seeing the Zoom group chat, so I can't see the questions that you're combing through to find these, to make sure that I'm answering it appropriately. But I maybe will start to speak to this, and I might ask you, Mike, to speak to it as well, because I know, having participated in your OHTs table, that there have been some really stellar examples of the integration of, or the inclusion of, a broad partnership within Ontario Health Teams as they're forming. So within the guidance document and the work that we've been supporting in the early formation of OHTs, we've set out, of course, that OHTs are expected to care for their full population, and noting that that population will be inclusive of, in almost every case in the province, Indigenous communities and the providers that support their care. And I think we're finding out, certainly through the implementation of that work, where there are best practices in supporting that engagement with the communities themselves, with the provider groups. I think we will want to support and share where those best practices have emerged. And I would say that there are other engagements that we're undertaking with providers who, do want to kind of maintain, and maybe they have a different funding relationship with the federal government. There are a lot of different structures within the province that don't necessarily make it obvious how they will become part of an OHT now or in the future, but they're very interested in understanding what we're doing, how they can become involved, and we've been providing some guidance along the way in partnership with other partners. We had a communication through the Chiefs of Ontario last year to sort of speak to how that might be approached, and I think we want to understand what further guidance or what further support could be offered to that effort. But I do think that there will be probably the most telling and obvious and most impactful experiences will be those of providers and teams sharing their experiences across each other.
Yeah, so maybe since you asked me to comment, I'll just say I imagine this is quite variable because the teams are quite variable, and just as there's quite a range of how deeply engaged primary care is in each of the teams and what stage they're at right now, that I would suspect it's similar for engagement of First Nations communities and other Indigenous populations within their groups in the process. I can tell you that here in our OHT development, we had organized an Indigenous talking circle to bring together the different Indigenous patient groups and communities in the region to think about how they would like to be involved or engaged in the team and how we can incorporate their perspectives into our own planning. But Karen, I don't know if you had anything more specific you wanted to ask. Everyone can actually talk, so if you would like to, if you have a clarification to your question or something specifically you'd like addressed, do you want to unmute and ask the question? Or if we covered it, then we'll go to the next one. Not hearing anybody. So we'll go, the next question actually, great, since this is a primary care research meeting, so it's nice to see a question on research. Question about primary care research priorities for the next couple of years, particularly as they relate to OHTs and primary care. And if there are any thoughts or comments from any of our panelists, if someone would like to take a go at that one.
Take a first crack, and then John Lavis, I don't know if you want to add anything. So I think that the OHTs offer a rich environment to do some research and to understand where we've come. So right from how was it implemented and what were the different successes in the different various regions, and how did primary care involvement, yes or no, contribute to the success? We do have to look at patient outcomes and system outcomes and understand what the impact of the investments in the health teams will be on our patient outcomes, and whether that is in the populations that we've identified that we want to concentrate on, or whether it's system outcomes, costing, etc. So I think that, I could probably go on for half an hour on all the various aspects. I think that the main challenge for us is going to be probably less around identifying what are the questions and more around identifying where we can get funding to accomplish some of these goals. And I know Mike and some of the PBRNs were trying to think about that. Simpson is trying to look at how we can pull some of that data. But really, this has to be a coordinated, integrated fashion. And it almost feels as though this is the kind of broad system-wide evaluation that could be done.
Yeah, and maybe I can do a little bit of a shameless plug for Inspire, as one of the organizers for this is there is a central evaluation group looking at evaluation of the goals from the ministry perspective, but this research network through Inspire, so everyone who is able to register for the meeting and connect with us, we're working closely with the Ontario Health Team candidates on identifying those research questions and trying to connect the research communities to people who have questions and might need expertise. So make sure you're on our mailing list, and we'll try and connect in with those priorities as they come up. The next one that's made it to the top is from Catherine Donnelly, and it's about expanding primary care teams and whether or not there's any plans to expand access to team-based care within primary care as a part of the OHTs, and how patients who currently don't have team-based care might be able to get access to team-based care as a part of a OHT rollout.
I think that one can be directed at me. I think we see for sure that the entire population is not being served by interprofessional models in its entirety. And we're seeing the importance and value of team-based care, particularly as we talk about integrated care in an Ontario Health team. I think, right now, that is exactly the type of question that we're trying to answer in the vision of Ontario Health teams, which is, can we look at what we already have and see how everybody's working together to serve and meet the needs of the community? So I don't have an answer to say, is there an appetite to look at, where there needs to be more interprofessional primary care models to meet the needs of the community? I would say yes, but we also need to make sure that we are looking at what are all of the needs in the community, what's already there, where are there existing partnerships that can meet the needs of the community. And I'll be honest, and maybe I'm not allowed to say this on a ministry call that's being recorded, but is that I think what will come out is a better understanding of where the need for team-based care is based on the needs of the population. So I would say, yes, it's a question that we need to answer, and we need to answer it in an integrated way. And I'm hoping OHTs can set that platform. And we know a little bit already. So we know where all of the interprofessional primary care teams are. We know where, they are working hard to serve the community at large. And we know places where there's a big emphasis of serving the enrolled patients, and more is needed to serve the broader community. So I think that's where we need to answer those questions. But I think, yes, there is, to answer your question more directly, do I have a dollar amount to expand team-based care? No, not right now, but I think let's try to answer those questions to understand community need better in an integrated way.
Great, thanks, Nadia. And the next question, I think, goes a little bit to where there are also resources that might be part of teams to serve patients, and that has to do with the LHINs and the various programs in the community that they support. So the question is, were LHINs engaged in how the OHTs would be developed and rolled out, and is there any kind of official handoff process from the LHINs to the OHTs kind of planned at this stage? Might be one people don't.
Yeah, I could start from a provincial, maybe, because I'm sure, I think what we find is that regionally or locally that can vary. I think that a lot of local teams have included OH in the local OH partners, so the LHINs, at their planning tables from the very early stages when they were still LHINs, and have done so both to kind of have greater awareness of what is out there, what is part of their system that they are planning for, and also to prepare for home care in a future state. From the province's standpoint, I think, we had high level consultations, certainly with leadership across the organizations as we created the OHTs. So that had been part of an overall engagement. And certainly the direction that was introduced through the Act, that was the first signal, and engagement starting around that time and continuing. We are very much wanting to continue that effort. I think those local partners that have had really positive impact from having local OH partners at their table will know that it can be a really helpful hand to have involved. And I have found it particularly really impactful, especially as the ministry takes this approach to talk with teams that we're asking to come together based on, they're currently looked to be overlapping in sharing a planned population. The OH partners have been very helpful in helping us to kind of understand more about those partnerships, and especially where they've been involved along the way. So I think there has been a lot of local engagement that I've seen, but I know that in some areas of the province that was not the relationship, and that kind of wasn't consistent. I think we're aware of that, and will want to kind of understand how to really support teams in an equal way with that type of local resources where they're available.
Great, thanks. And I see a couple, if people want to look at some of the links that have been thrown into the Zoom chat, David Price has put up a link to the Primary Care 2025 and Rick Glazier to one of the reports that we've worked on geographic variation in primary care and teams. The next two questions I think are actually probably directed mostly towards John and David, because they were about, oh, so one dropped down. I'm going to make sure I ask this question that was posted yesterday, just for being the first one up. And the first one that I'll ask is one that I had posted, which is your discussion about your pre-existing relationships in Hamilton seem really critical to your team. What's your advice for areas or teams where they don't have that same history, and how critical was that for you in really pulling your team together?
Maybe I'll go first, John, and then turn it to you, because I can talk about the history. It was critical. The whole thing was based around relationships, and I think that's one of the critical aspects of this is, public health, we have the luxury that public health, the medical officer of health for Hamilton is in the same physical building as I'm in, and her office is just down the hall. We had developed quite a close partnership between public health and the academic department, which then had expanded out into the community primary care. So I think that was critical. We certainly had willing receptors in the hospital CEOs willing to bring primary care in as part of the Hale table that John talked about in his introductory remarks. And this had developed over time. Just because it doesn't exist now, I'm not sure is any reason not to try and start it to happen now. There's no question that those relationships and understanding the pressures that the hospitals are under is critical for primary care to understand that, and vice versa. And really, I think the secret for me is bringing in public health, home and community care, social services, the whole breadth of all of those primary health care activies. And that, I think, has made an enormous difference as we've gone through. So yes, it's critical. If you don't have it, now is a great time to start, is probably where I would suggest. But I don't know if you've got any other observations, John.
Yeah, I do actually. I mean, it's a very foundational, fundamental question that's been posed, and it's at the same time both complicated and simple. Complicated because what's involved in building what Hamilton's built over time are easy little things like ego and power and role and sharing and all those kind of fundamental kind of things. Inherent in all of that, I think, is a notion of leadership, of people who have the vision and the capacity to pull people around a table and get them to see the benefit of a more integrated, collaborative kind of approach. So did it make a difference in Hamilton? Absolutely. I don't live in Hamilton. I grew up there, but I don't live there. And when I came to be involved in Hamilton Health Sciences as a patient advisor and first got involved in this whole exercise, I started to learn about all of that history. It brought back to my memory, and I'm sorry to be doing a personal experience kind of thing, brought back my memory of being a city manager many years ago, both in London and in the GTA. And it just caused me to reflect on the number of times when I really had to take the lead to pull people together and try and get them to see the benefit of shared ownership of an idea. I've said a lot of positive things about the government's initiative to develop OHTs. I think it's a far better model than the LHINs, mostly because it's a bottom-up kind of thing as opposed to a top-down thing like the LHINs were. I was going to say this earlier and I held myself back. Sorry, Alison and Nadia, but the real long-term proof of the pudding here is going to be the Ministry of Health and Ontario Health letting go.
Okay, great. Thanks a lot, John. Yeah, I'm going to go just because I think this question was actually asked yesterday. So Maya came on early, looked at the panel, and already had a question up first. I want to make sure we get to it. And that's what was the biggest challenge for you, I think, in working with OHTs and working to develop your OHT professionally and personally? And that can go to, again, I think probably David and John, thinking about your personal experience in the Hamilton team.
You want to go first, John?
Sure. You know, I'm going to sound like I'm some kind of a salesman or something, but challenges haven't been my biggest issue here. It's been frankly pleasure with experiencing the kind of cooperation and collaboration I've seen. Yeah, there are a ton of issues around logistics and implementation and funding and personalities and all that kind of stuff, but I don't really think I've had a moment of frustration in all of this, because we're building on that solid foundation that I was trying to describe in my long-winded answer to the last question. Don't know what to say beyond that.
So I'll just echo that it's been a very positive experience, but I think the challenge has been, from a primary care lens, twofold. One is oftentimes our primary care colleagues understand and see what is needed for their patients. And I'm thinking of home and community care, social services, and so on. And it's really, really hard to connect our patients with what we see as being really critical services for them. I think the other frustration, if you will, is dealing with large organizations that are the hospitals. They are massive organizations that are billion-dollar organizations, and we're little pipsqueaks. And it's tough sometimes to get their attention. It's tough sometimes to get them to change course. And they are not, by definition, nimble organizations. I think the leadership has tried to make them so, but it is very difficult to change fundamental infrastructure in something like that. So it's still a challenge. We're getting there, perhaps, but we certainly have a long way to go, and we're by no stretch of the answer there yet.
Just build on with a quick comment to what David just said. You know, one of the magic parts of what's going on in Hamilton are two hospital leaders, Rob McIsaac and Melissa Farrell, who have really come to the table in a way that's about understanding and respecting the small players and trying to say it again, work collaboratively on that stuff. There's not a lot of domineering ego there, and I've been around the hospital world long enough to know that some of that exists, but it's not one of our challenges.
Okay, great, thanks. The next question, I think we had a kind of a partial answer to funding, but this is from Camilla about funding primary care leadership and understanding that, yes, there's some supports for OHTs that could be used for that, but how do we make sure that that is supported? And she's got a quote from a talk she went to earlier today from Dr. Judy Brown about volunteerism not being a sustainable model for running this thing in the long term. So anybody with, I think anyone on the panel could probably tackle that one. Any thoughts about how to, is it a matter of convincing? Is it a matter of more direction in terms of how resources are put out, or is there another way to ensure that primary care leadership is supported?
Maybe I'll start, Mike, before people can give answers that maybe sound more action-oriented. But I think part of what we've been struggling with in this OHT work from the very beginning is to not pretend that we know the answer to what needs to be built locally, and not have broad parameters to work within so that people can create that space based on what their community is made up of, and I think what their primary care system might be made up of as far as their leaderships that might be engaged. So we have heard from a lot of different partners that already, as soon as the funding was announced, people started creating their plan for how they would allocate it, and there's already concern about how that's coming together, and have said to us, are you going to give guidance about how it should be done? And we've said, we should is a hard word in this case, and I don't think we know the answer, but I do think we want to hear from people about what practice people have undertaken to deploy their funding in this area or in others. That there are other categories of spending that are available for the approved OHTs. So I agree. Like I think we've heard it firmly enough that I understand it is a very common concern across a lot of groups. A lot of those that are on the line today that have talked with me about it. But it is a challenging position for the ministry to, at this point in time when we're just not even having sent a dollar out, to steer that money when the local partners might know how to do it best. So can we course correct after it's gone out? I think we want to find out and hear from partners about what the best processes they've put in place. So how we can get that intelligence is something that we'll be interested in pursuing. But I think we're aware of that risk and want to kind of understand how to manage it as it rolls out.
Anybody else on the panel want to take a crack at this one? Nope.
I'll just say it one more time. To me, it's the beginning, Alison, of the process of letting go, and so the less prescriptive you are, I think, the better. And it's going to be really good proof of the pudding about the accountability of how fledgling OHTs use money like that, and the ones that do it wisely and thoughtfully should get a big tick mark, and the ones that don't should get a big raised eyebrow. But it's going to be difficult to determine who gets tick and who gets eyebrow, but it's I think a part of the process of maturation of letting the kids spend their allowance where they think it's most appropriate to put it.
I like
Great.
that analogy a lot.
Thanks. And I think there's a comment in the chat there as well about accountability needs guidance. The next question I think might be good actually for John Lavis. Maybe John, I think you might be a good person to talk about the coaching program that was mentioned and who's providing that.
Yeah, so we're close to being able to talk about it, but we're not quite there yet. So we've been working with the ministry for a while to figure out what that will look like. But what we do know is the coaching is going to be focused on population health management, which again, I think is something that many primary care folks that have rostered populations are quite familiar with, but it is a sea change for folks working in other sectors. So we're currently in the midst of a set of conversations with two different partners about who might be best positioned to roll out coaching, but the idea is to complement the kind of high level inputs that we've been able to provide today with very practical face-to-face or nowadays screen-to-screen conversations about how to operationalize this. So our hope is within a few weeks, we'll be able to start to talk about it and offer it up to approved Ontario Health teams.
Great, thanks, John. Next question is one I know there's probably at least a few people either on the panel or on this call who might have some thoughts on this next question. And it has to do with the fact that family physician billings are outside the scope of OHTs, and participation is voluntary, but we're supposed to cover everybody. And are there any thoughts on any incentive structures or changes to payment models that might evolve to address that? Because I really don't see how you have an OHT serving a whole attributed population if you can't have engagement of all of the primary care physicians who are serving those patients. So any takers for that one? There's gonna probably be dead silence on this one.
I can start. I think looking at different payment models in this province is an important discussion to have when you're trying to look at integrated care. And I'll just be very honest to say that, you know, there are mechanisms in place where compensation discussions need to occur at different tables. But I think, you know, saying that we're not going to even look at different payment models when we are thinking about integrated care, I think I think we need to look at what we have in place today and how those models are meeting objectives, and then we need to think about what are the tables that we go to have those conversations, given, you know, there are requirements that we have where we talk about physician payment models and other models.
So I think that I don't want to really go into the specifics about physician compensation. As Nadia's alluded to, there's lots of different tables that are looking at that. It's not just about compensation, though. It's about making the life of the family doctor more manageable. And usually that means making the care for their patients more seamless. And so one of the concepts that we've been sharing with our family physicians, or at least we're sharing prior to COVID, was how do we make your life caring for your patients here in Hamilton a little bit more seamless, a little bit less bureaucratic? How is it that we can help you to access specialist care? How can we help you to access information about your patients who've gone off to see a specialist and have had investigations? How do we make the wait list for specialists shorter? In other words, how do we make the practice environment for you more congenial such that it lowers your stress? And that is a win, which is perhaps not monetary, and it's not an incentive, a monetary incentive to join the health team, but maybe it's a real incentive that is going to improve how you do business. So I think there's more than just the monetary.
Great, thanks. And I think, John, do you have your hand up as well, John Fleming?
Yeah, I do. I just wanted to say if there's a third rail topic anywhere in all of this, that's it. I really want to endorse David's comment, because in our conversations in Hamilton, a lot of what I hear from primary care physicians has been, if we can make the system work better so that I can do an easier job or a more effective job of referrals and all that sort of stuff, then that's a bonus to me. But I can't imagine at this stage of maturity of OHTs that physician compensation is a third rail we want to put our fingers on.
Okay, great, thanks. Next question is about home care, and I'm looking at our time. We got about 10 minutes till we're at the end, and I've got a couple of little wrap-up announcements at the end. So maybe we'll do this question, and then I'm going to ask if the one after looks like it was a comment on a previous question, so I might ask Barb to clarify. But that's with about home care. So with home care moving, will they be moving maybe to Ontario health teams? How can we move away from a task-based home care system, which doesn't seem to work very well for people? I know this has been a topic for discussion in our own OHT, has been actually, I think, the foundation of how we're thinking about trying to improve care. And if anyone has thoughts or comments on the ability to change the current model of home care, which is very kind of transactional and not coordinated as a team.
I don't know how to answer that one, Mike. You may have noticed I've been texting back and forth because I had a patient discharged earlier today who requires home care and palliative care, and trying to coordinate that. And thank goodness we've got a couple of home care coordinators in our family health team that are linked to CCAC. Otherwise, I don't know how I would manage. But I think that we're unique in that sense, and home care needs to be much more closely linked with primary care. One of our challenges, I think, in primary care, and I don't know who's from the hospitals, but we have concerns about the bundled care model, where patients go home with designated primary care that doesn't necessarily coordinate and integrate with primary care. And there's more than just sending somebody home who's had their recent surgery with a specific targeted home care, because it really transcends that. And I think that's the issue for the patient that I'm dealing with right now, is it's a multifactorial thing, and I can't do that as a primary care physician. So how do we better link with our home and community care? And that is going to be one of those areas that's going to be a win for our primary care colleagues across this province if we can better integrate that. And it's fundamentally not, as you say, a transactional thing. And it always happens Friday afternoon at 2:30. I need home care there, I need it tonight, and I need to be there tomorrow because I need the palliative care nurse to join me tomorrow to do some of this work. And so how do we make that happen more seamlessly? And I think that's the holy grail for our primary care aspect of the Hamilton, or the health teams writ large.
Seems to me that home and community care is such an integral part of what integrated care really means. I can't imagine a model where OHTs aren't given some kind of ability to influence the shape and the direction and the and frankly the allocation of resource to that incredibly important tool.
Maybe I'll just start. I think there are also, to be very frank and honest, there have been legislative and regulatory barriers to support the, connections between home and community care. And I think, I think there's been some movement on removing legislative barriers, but I think it's the more important part is how do you implement that legislation, on the ground to make that happen? And how do you make sure that where patients are accessing care, there's an ability to, provide that care coordination and home and community care in a way that makes sense, is not, I'm not caught up in, legislation and regulatory pieces, but I think Alison might have a comment that she wants to add to that.
Yeah, and I would agree with Nadia. I think, the way that we had structured the initial full application, we had included an appendix that was essentially saying, blue sky, how would you build home care? And our home care branch, which is part of my division, purposefully, because the delivery of OHTs and the delivery of a transformed home and community care model are one and the same. And the home care branch had taken those ideas through that Appendix A of the full application from the first round, and helped to inform that legislative recrafting and the work that they're continuing to do on setting regulations related to that. But we know that the OHTs right now are sort of saying, okay, but what about it? What am I building now? And what are the kind of rules of operations? And that's what I think we want to give more clarity to in alignment with work underway to set regulations through that mechanism, or through that scheme. And I would agree with David. I think, where we had kind of tested integrated care across two sectors through bundles, which is hospital to home, it was very much not the full triangle beneath the little iceberg cap of what home and community care does for the patients. And I think we heard from a lot of our community support service providers and our home care providers in the early days of OHTs was that While, you know, the future was a little bit unclear about what OHTs will craft for a new home care world, that the participation at those OHT planning tables, they knew had been eye-opening for all the partners that they were talking to the hospital groups, to say, this is the full range of services that we provide. And when we talk about delivering home care transformation, it is not just 60 days post-acute, it is whole health connection into primary care and other aspects of a full and coordinated continuum of care. So who better to craft that than the OHTs as they're forming. So I think there'll be a lot more information to come on that. But it is purposefully arranged as transformation initiatives, you know, duly tracking the OHT implementation in the modernized home care.
Great, thanks, Alison. And I know that's been in our own OHT. That's been hugely important. And there's a couple of comments in the chat about handover. Thinking that original OHT document, we keep going back to the one line that says no cold handovers. Always knowing where your patients are and what services they're needing. So I don't know, Barb, did you have a particular comment on Northern Ontario? Because I lost the question one that you were referring to. I've lost track of which one it is. And if you want to unmute yourself or put a more detailed question in the Zoom group chat, I'd welcome that. Unless.
Hold on. Sorry. Okay, I'm wondering, can you hear me?
Yes.
Okay, so thanks so much for the opportunity to say hello. I'm actually so grateful to be participating. I'm actually on call in Emerge in my small community of Marathon. So living, I think, what is being talked about in terms of the importance of continuity of care. In fact, in the last half hour, I put a cast on a little 2-year-old who was seen in the clinic with some tenderness in their forearm and put the cast on while listening in. So pretty seamless, I think, integration of primary care as an example. What I just had wanted to highlight was around the conversation around the remuneration. And I understand there've been sort of, we're not going into detail, but just to highlight some of the challenges in our rural communities that still remain under-resourced from a primary care perspective, but recognizing, as this conversation has, about really the importance, especially I think in our smaller and northern rural communities, about how integral primary care is, obviously in the development of OHTs, the delivery of care, and also I think we're, the other hats I wear is sort of creating a practice-based research network for NOSM and the clinical sciences division head. So the multiple roles we play, and I think the importance of kind of recognizing, as again, I hear the conversation happening, but from a ministry perspective, just reinforcing that need for remuneration for leadership, and also consideration, I think, in terms of some of our more dated contracts around physician, nurse practitioner type complements, is what I'd say, and really echo the importance of the home and community care conversation that happened. I think we have struggled over the years, and finally, after I think about 10 years, have taken on the home and community care services through our primary care clinic, and it's been much more seamless in terms of the care that's being provided to patients, which really is our goal. I know that I can see less people in Emerge if there's good primary care in the clinic setting. So those were sort of more reflections on the comment, and thanks for the opportunity.
Great, thanks, Barb. There's a couple of other comments and then we're actually at the bottom of our questions. So I think the question that Jennifer has, we've had a lot of discussion on the engaging and funding for primary care, and we could I think that's something that everyone agrees definitely needs some more attention. And Kathy Thorpe has a note just that as a part of our Inspire group, we're also working on some research on engaging family physicians in the OHTs and FP leadership. So thanks to Judy Bell Brown, and probably thanks to many of you who may have participated in some of her research in your roles within primary care and your own OHTs. with that, I just want to thank our panel, and we can do a kind of I know Rick this morning did an unmute and everybody clap, but however you want to do that, either with claps in the chat, so we don't all get feedback. But thank you so much for all of our panelists for joining us.